Good morning. I'm Christophe Lambert, the President and CEO of Helix. There's some slides on your chair, copies that I'll be useful to see some of the graphs and follow this with me. I'd like to talk about where we can focus our innovations for disease management, detection, and prevention. I was really stepping back and saying, innovation needs to be applied to essentially all of the tracks, the other tracks that we're actually not able to participate in. And I come from a perspective of I've worked in pharma early in my career, and I've worked at building a small company in the field of bioinformatics. And you really end up asking the questions, well, how is what we're doing going to make a difference to the bigger picture? And if it isn't, what are the transformations that we're going to need to think about, short-term, medium-term, long-term, in order to really make a difference? And so on this first slide after the title page, framing the problem, the biggie, of course, in America, and it's also rising in other APEC economies, is the disconnect between how much we spend of our GDP on healthcare and on the next slide, what results we're actually getting. I was able to pull 2007 numbers for APEC member economies, looking at life expectancy versus percent GDP, and you see in the upper right is the United States of America, on the lower right Singapore, and Singapore's spending under 4% of their GDP on healthcare, and their longevity, which is the other axis, is up somewhere in 82, whereas the United States is somewhere around 78 at the time the state was elected. And so it's not to say we should all, we probably learned something from the Singapore model, although there's arguments that the society is different, we wouldn't be able to apply some of the same controls, for instance, that have been put in that nation. But the point it does make to us is just spending is not sufficient to get the outcomes. And so there's three main facets on the next slide that I'd like to touch on briefly in this talk. Is how do we deal with the disease management side? And I'd like to talk a bit about a topic that hasn't really been covered much at this conference, which is operational excellence. There's some amazing stories of transformations of hospitals and clinics and so forth to get more out of the existing scarce resources. So the assumption that we've got to just spend more to deal with the big bulging baby boomer generation and the aging challenge we have, we might be able to challenge those assumptions by looking at some of the success stories in operational excellence. I'd like to talk to something near and dear, which is the idea of longitudinal disease detection prevention, something that specifically speaking a bit about biomarkers, which is my area of expertise, really looking at the idea that we know the expenses are late in life, they're with the chronic diseases, and it's been talked about at great length how prevention is really the key. And it really goes back to Deming, who looked at variability in a system gets amplified over time. So if you deal with the problem early, then there's less chance of it magnifying. And then finally talk a bit about productive longevity, how lifespan increases. We've seen it's been something like 10 years of lifespan gain in the last 50 years. What if we were to have a dramatic jump in the next 10, 20, 30 years? What would that mean for where we have to put our attention? So next slide, talking a bit about operational excellence. Really a lot of the problems in healthcare are operational. We've got too long wait times. The notion of waste in manufacturing, well, what's that mean in healthcare? It means people dying. It means, adverse drug reactions killing 100,000 people in the United States. It means hundreds of thousands of avoidable mistakes, things like that, that if it's avoidable, it's going to have to be dealt with through process improvement. And of course, we hear about nursing shortages, the baby boomer bulge is coming, and we know, at least looking at those curves on that first slide with the United states up at somewhere like 16% of its GDP spent on health. It's not sustainable to just throw more and more resources. And so, an area, it's interesting when we talk about innovation, we usually think science, right? That we're going to have these new breakthroughs in medicine that are going to be the answer. But really, there are some amazing innovations in manufacturing excellence that have been developed over the last 10, 20, 30 years, of course, starting a large degree in the quality movement in Japan. There's approaches come under different names, theory of constraints, Lean, Kanban, Six Sigma, that have been migrating into the healthcare systems. And there's some amazing stories, and you can go read this reference and get some additional ones of the worst performing emergency room in Great Britain being transformed into the best over the course of a 3-month transformation. And what they find is you don't have to improve everything. You have to focus on what is the rate limiting step within the organization. And in the case of hospitals, it's typically the operating theater. You can typically get double the capacity out of it by better scheduling and making sure the resources are all there. Or admissions, or sometimes bed capacity. It ends up being, again and again, the same areas of hospitals that if you put the attention there, perhaps applying Six Sigma quality programs on things like mistakes and so forth, you can get dramatic outcome improvements, dramatic improvement in resource utilization, essentially for almost free. And it's kind of seems unbelievable, but this stuff exists and is published. And how do we get it sort of operationalized? And I really asked ourselves a question in national healthcare systems: do we have the equivalent of chief operating officers? Right? Typically, an MD is the chief, medical officer or surgeon general or whatever of the country. But think about someone who's a really high-level skilled person who's run global supply chains, who's transformed manufacturing operations and so forth, having that level of expertise brought right to our healthcare systems. So enough on that, but it's really, let's exploit what we have, and there's a tremendous amount to be done there. So then an area on the next slide of detection and prevention, which I really put together because it's kind of a continuum. If you look at the current state of it, of course, in developing economies, there is huge returns on spending on things like vaccinations, immunization, doctor checkups, antibiotics, the primary care, basic sanitation. But then you get to where we're at today, where the screening of disease. Look at lung cancer. 40% of people are caught at stage 4 for lung cancer, and so. And it's, you got what, an 8-month median lifespan after that. And so the screening approaches, of course, give us an improvement over nothing, but the current state is of course that rather abysmal discovery. And we know half of us are going to get cancer at some point. This is very personal. So how are we going to get to the place where we can have early detection that's actionable? Just skipping over some of those other points for time. What I would propose, and of course we work in the field of genetic research, and to be, honest and frank, and a lot of what we do in the field of genetic research is discovering these biomarkers that explain only a small fraction of the variation in disease. They're what you're born with, and it doesn't represent the ongoing trajectory of disease. And so what I would propose is where we'd really look at making research expenditures is in the longitudinal capture of biomarkers at high frequency. And that could be genetic, proteomic, it could be metabolomic, small molecules in the urine, etc. And the idea is, we're getting a pretty good understanding of what genes are involved in what diseases. And when you're healthy, you're going to have this constant, within sort of normal variation, fluctuations of all these various indicators in your body. And then when something goes wrong or begins to go wrong, there's going to be a transition. And so to get from transitioning from the place where we're talking about, one-size-fits-all healthcare policy, things like salt is bad for everybody, we got to lower it, and turns out there's studies showing it's not necessarily so solid, that science, and we've been practicing it for 30 years, is getting it to each individual person, a rapid feedback loop whereby if you really want to change behavior, you can't ask people to do something that maybe in 30 years will make a difference to their life expectancy. You need a feedback loop that tells them, as a result of taking that drug, or a result of changing your diet, or a result of exercise, you've increased your expected lifespan. You've dropped certain indicators that for you are you're at high risk for, say, a cancer in your family, and you've kept those cancer promoter genes in check. So right now, the state of that in terms of R&D, almost nothing's being spent in that area. There are a few leading edge groups working on it. It's a chicken and egg problem. You're going to need to collect the data before you can turn sort of the informatics and bioinformatics analytics on it. And of course, there's have to be all sorts of interesting questions answered in terms of infrastructure, electronic medical records, public policy, and so forth. And so I'd advocate, the biggest obstacle to this from a technical point of view and sociological point of view is, what does regular measuring of biomarkers mean? It's like, well, stabbing yourself with a needle once a day and getting a blood draw and sending it in, it's not viable. So thinking about device innovations whereby you can capture that information regularly start with the most at-risk groups that it really matters to them if it is going to be invasive. So right now the technologies are such that it's still fairly expensive to do some of those assays, but it's dropping like exponentially. And so we know in a few years it's going to be $10s, $20s, $50 to do a lot of these genetic tests and measurements that we're doing today. And on this next slide, which has a funny picture of a toilet from the Shanghai Expo, the idea is, imagine if you just flushed your toilet and the mass spec was done on your urine, and, in other words, you don't have to think about it. As Rob was saying with vaccination, the biggest problem is adherence. And so how do you get systems in place whereby you don't have to worry about it? Well, it's not science fiction. There are glucose monitors that are put subcutaneously that every 5 minutes read your blood sugar levels. And we really do see evidence, including people just pricking themselves with these glucose monitors, that when they have that instant feedback loop, they're making the right decisions about their diet, they're making the right decisions about their lifestyle. And so, in a sense, we need to get out of this, I think we're going to need to get out of this mode of trying to focus on these silver bullet, this is bad for everybody, this is good for everybody, and trying to somehow cajole and influence our populace to do that, versus getting to a personalized, this is right for me, and I can see it right in the data and make those decisions myself. So finally, of course, if this all works out, productive longevity sort of becomes the question. There's some amazing stuff happening in aging research. I'd say this prevention will lead to extensions in life. And there's all sorts of promising molecular research on like telomeres, calorie restriction mechanisms, and so forth, that it wouldn't surprise me if in our lifetime we see some dramatic boosts in longevity. So obviously there's going to be some real questions about, do we retire at 65, or does it eventually become 90, 100, 120? It seems crazy to talk about it today, but if you look at the exponential growth of human knowledge for the last century as we follow the scientific method, these things could well be, within our lifetimes, if not our children's. And then finally, and then the key point I'd like to make is if we know that end of life, yes, it is still going to be expensive, but if you can have a 100-year lifespan or longer, where a lot of it is productive, and I really appreciate the plenary talk that was discussing about productive life years or quality of life adjusted years, we have the potential to essentially sock away the resources to pay for when it eventually really does become important to spend on those last years of life. And then finally, sort of as the people thinking about public policy and metrics on this last slide, consider the prime metrics that we use in looking at healthcare systems. Especially in private systems, the way we think about measuring it is payments are basically received based on treating illness. And so if we believe measurement drives behavior, and essentially corporations and doctors and so forth get paid for treating illness, doesn't that mean the more illness you have and treat, and the more treatments you do, the more money you make? And eventually, as we see in the crazy curves of percent GDP, it just sucks right into your economic output and eventually becomes unsustainable. So I think we need to think about ways to measure healthcare on throughput, looking at this operational excellence, on sustaining health and lifespan and high quality lifespan, and essentially, start looking at how we can really build the metrics that lead to the right investments, in these various facets that I've spoken about. And the idea is we can increase our lifetime economic output, increase the funds to improve health outcomes, and really you say, well, what the real thing when you look at it from an industry perspective is, well, what if we were to essentially eradicate disease? How are we going to get revenues? Well, it's there's always, I think there'll be a huge shift to where the expenditures are in prevention, and there's the longer and more healthy we are, the more money we can have to put towards prevention. So that's really where the markets are going to be, and thinking about pharmaceuticals and the transformational shift. How are we going to get this personalized medicine stuff, building drugs, knowing that each person's a rather unique organism? The blockbuster model is already cracking at the seams, and I think Sanofi's a lot more looking at the targeted markets, and pharmacogenetics is a part of that. But gosh, it's hard to envision one drug for one person. So there's these poles of personalized medicine versus we still need to apply things that can work for large segments of populations at least, and looking at how we can get the R&D costs and bringing things to market costs, clinical trial costs down, or change our model so that we don't have to, so we can treat those 6,000 orphan diseases that aren't treated right now. So thank you very much.
Thank you.
One of the areas that's very interesting in genomics is this field of cytogenetics, where you historically they've used karyotyping, and you've seen these stains of chromosomes, and they basically look at a microscope and see if Johnny's got an extra copy of chromosome 21 while he's got Down syndrome. So you could see these really big structural abnormalities, and for the last 30 years that's the way it's been done. If you look at the clinical yield on that, any idea that it's actually 3%? In other words, clearly the child's got a deformity or mental retardation or something like that. 3%, they actually find something abnormal. Well, now they've moved up to, with microarrays, higher density, getting more information, 20% clinical yield. And then they're talking about, well, in the future we're going to sequence the whole genome. But the conflict is, and I wrote a whole article on this on my website if you're interested in seeing it, on cytogenetics, is back when there were these massive deletions or extra copies, it was pretty darn certain that's what was wrong with Johnny. You weren't worried about being wrong. But now there's all these variants that are, well, we're not sure. And then with sequencing, where we're going to up the information even more, we're going to have to shift things to a place where we're going to have to recognize that there's a lot we don't know, and we're going to, again, the longitudinal thing, we're not going to be able to just give one answer today and, okay, now, you're in the 20% who's diagnosed and you can believe that. We're going to say, look, there's these things of unclear significance, and we're going to put you on a plan where in the future we'll let you know as we learn more. And you'll have to revise your mental model of what your disease is. And unfortunately, we live in a society where it's actually unscientific. Have you ever heard the phrase scientifically proven? It's an oxymoron, right? And yet you see it in all the ads. And how do we take science into public policy where the truth is we can science is about disproving your previous models and replacing them with better ones, whereas in public policy we want absolute certainty and sue you if for some reason you were wrong, when science teaches us that nothing is knowable, only that we can have done our darndest to falsify it, have a good working hypothesis, and update it as we learn more. How do we get that into our harmonization of legal and regulatory?